Well, good afternoon. This is Brenda Hampton with the University of Illinois Chicago Behavior Health Crisis Hub. And I am pleased today to have you at the table for our first quarterly Subregional Committee Learning Collaborative. We're testing the waters now. We want to see what the response is to a learning collaborative because our interest is to keep local level planning going and to bring you information from a national level on different ways and processes that states have used in order to do local level planning, particularly as it relates to the continuum of crisis services and crisis response. We worked with a national expert to advise us on states that were really proactive and states that really had a message to share with you about their local level planning processes as it related to the crisis continuum and crisis response. So I was introduced to Jane Mogavero, and Jane is going to be bringing you information about how in the state of New York, particularly Erie County and Buffalo, they went through their processes of bringing people to the table and how bringing people to the table evolved into very great work at that local level. Jane is executive director of the Patrick P. Lee Foundation, which is a private foundation dedicated to advancing education and improving mental health outcomes. With approximately a $60 million assets, the foundation distributes $4 million annually while planning for significant future growth. In mental health, the foundation focuses on improving systems of care for adults living with serious mental illness. Recent initiatives include strengthening the behavioral health workforce, expanding access to innovation treatment services in Western and Central New York, and partnering with regional stakeholders to reimagine the mental health crisis response system in Erie County. Jane founded the New York Funders Alliance Behavioral Health Funders Initiative and has moderated national discussions addressing behavioral health workforce shortages and emerging legal and policy challenges related to the Americans with Disabilities Act. She also serves on the Erie County Community Service Board and co-chairs its mental health subcommittee. She is also the board of directors for the Center for Hospice and Palliative Care. So I am going to turn it over now to Jane to talk with you about Crisis to Care Collaborative. Jane.
Thanks, Brenda, and thanks everyone for participating today. I'm really excited to talk about the work that's happening here in Erie County and also eager to hear from all of you about what's happening in your communities, what resonates with what I'm sharing, and maybe what we can learn from each other. Um, as Brenda said, we are, located here in Buffalo. I'm going to give a little background information before we dive into the deck, just about what Erie County sort of looks like. So we have about 1 million in population in Erie County, and Buffalo would be the largest municipality with about 300,000 people. Some of the positions I'm going to talk about might sound, similar positions, but differently named for your state. So I just want to identify what some of those will be. We have a county executive. Right now, he is a Democrat. He was elected. He is the head of our county executive branch, and he supervises all the non-elected department heads for the county, which would include the county mental health commissioner and the commissioner of central police services, which we'll talk about a little bit later. There is a county legislature, which is also elected. It's a mix of both Democrats and Republicans, and they would approve the county budget. And then we have a sheriff for the county who is also an elected position, and he is a Republican. So we are diverse in our political leanings. And I think that, as we go through this conversation, you'll realize this is really a bipartisan issue that brings everyone to the table. I recognize that each state is unique, and New York probably in many ways could be different from Illinois, but I would equate that, your Chicago would be like our New York City. And so if that gives any relevance of where Buffalo falls in that, we are much, much smaller. And our neighboring county has only 200,000 people in the whole county. So we are in western part of the state, but really surrounded by some rural populations. And with that, I'm going to go to the first slide. Thanks, Jessica. So as Brenda said, I work for the Patrick Lee Foundation. We are a private foundation, which essentially means all of our assets came from one place, which is Patrick Lee himself. We focus on mental health and education, and like many private foundations, we arrived at that space because the Lee family had a son with schizophrenia. So they were very impacted by mental illness. Sadly, Pat, the son, has passed away, but it certainly guides a lot of our work in this space. Next slide, please. So, what is the role of philanthropic partners at the table when we're talking about crisis care and crisis response? We really view our role in a couple ways, and one is a convener. We're sort of like a Switzerland in a way. We can kind of bring a lot of parties together that might have had some challenges working with each other before. We definitely have the ability, like Brenda said, for her organization to engage national experts and bring some opportunities for learning within the community. And, we just really can kind of plug in holes sometimes that maybe could eventually be paid for with public dollars, but it would just take a little bit longer. A lot of the work that I've been doing for this collaborative is project management, actually. So we've been hiring consultants to help with some of the larger work, but we really needed someone to sort of make sure things kept moving along, and that's something that I've been doing for the group. Next slide, please. So what are the key takeaways? I think these challenges will all feel familiar to you if you've been working in this space, right? It's fragmented. The situation is much more complicated than I think the average community member might realize in terms of the different systems and sectors that are intersecting around crisis response and care. And a lot of times we don't have the data to sort of prove out what we know is happening. So we hear a lot of anecdotes from law enforcement and from behavioral health providers, but oftentimes we don't have hard numbers to sort of react to and help inform our decisions. And people are frustrated. Everyone's frustrated, right? I think when this began, I would attend county meetings and everyone knew the system wasn't meeting expectations, but we didn't really have a plan forward. So if you can go to the next slide, please. So this is at a high level what our sort of topics are going to be for today. And again, I welcome questions in the chat, or if you have a clarification question you need answered, please feel free to do so and interrupt me along the way. But let's just jump right in. So next slide, please. So why was this a priority for our county executive? And you can sub out the word county executive for any elected official or anyone who's involved in this system, right? We aren't getting the right help to the people that need it. We are relying on first responders. And not only are they short-staffed, but they aren't often in the best position to be responding to this, whether it's training or just a comfort in dealing with mental health crises. And it's not really a good use of our dollars, right? We're spending a lot of money on a system that isn't really producing the results that we would all want for ourselves and for our loved ones. So next slide, please. So one of the things that we realized, and I know you all know too, is that there's no one person or system that can make all the decisions, right? No one sector controls the map. And so we realized pretty early on that we needed to create a team of those different sectors and the leads of those sectors. So in our case, these are the elected officials and nonprofit partners that we identified as being important at the table. And why we identify them is that they all have the ability to make decisions and adjust policy for their different sectors. So you'll see we have the county on there, we have the mayor of Buffalo, we have the CEO of our largest safety net hospital, which also operates a psychiatric emergency department. And then we have the sheriff. And later to the game, we added on the commissioner of Central Police Services. So for us, that's really the head of 911. So he is an appointed position by the county executive, but really functions almost independently in the work that he does. So depending on what county you're in or what region or community, your team might look different. Like if I was to put this team together at our neighboring county, Niagara, which is a much smaller one, they might have 2 or 3 people on that leadership team because their county provides a lot of the services directly. So they wouldn't necessarily need some of these other positions. And they just are a little more streamlined because of their size. So again, this is who we identified as being important to our decision making, but it would look different in each community. And I will point this out. I'm sure you're not all following Buffalo politics as closely as I am, but we are on our 3rd mayor in 3 years. And I share it because that's why these positions are important, not necessarily the person always sitting in that position, because it's going to change. There's going to be elections, there's going to be transition, retirements, you name it. It really was more the seat that they were holding that we were prioritizing. If you can believe it, we had the same mayor for 20 years. So to have 3 in 3 years was unexpected and certainly delayed some of the work we were doing, but also every mayor that sat in that seat wanted to be a part of this because the work is so important to the community. So we want to go to the next slide. So the way that we're approaching the work here in Erie County is using the SAMHSA model of everyone experiencing a behavioral health crisis should have someone they can call, someone who can respond if needed, and somewhere safe to go to help with their recovery. And so this really became sort of the mantra of all of our leadership team because it was something they could actually really get behind, right? You don't have to be a mental health expert to know you want to call someone in an emergency, you want someone to show up, and you need somewhere safe and helpful to go. So this really will guide all the work that we're going to talk about today and is how we're structuring our approach. Next slide, please. So now we're going to get into what exactly is the Crisis to Cure Collaborative and how did we get here? So next slide. Oh, there we go. So this work began, honestly, you could say 10 years ago. I think there were committees and different groups meeting around crisis response, but really things started to come into focus for us in 2024. At that time, I was sitting on a county committee that was called the Crisis Care Continuum, and it involved everything from preventing the crisis to the intervention during a crisis to post-discharge from the hospital. And honestly, it was really daunting because you didn't know where to start. And so what we decided as a group is like, let's start from the point of when the crisis is happening. Not to say that the other ends of the spectrum aren't important, but for us, this was going to be our starting point. And what the Lee Foundation did was bring in some national experts, but you could use regional consultants too, to sort of help us understand what was actually happening in the community. And so this initial committee came up with 50, I think it was like 60 people they wanted to talk to. We connected with 50. And they represented all these different sectors, right? Elected officials, hospital, first responders, advocates, behavioral health providers. And we asked them sort of all the same question. Who can someone call an emergency? Who will respond and where can they go? So if you can go to the next slide for me. And these were all the different places that they talked about. So the yellow bubbles are all the places that were named for where someone could call in an emergency. And then the blue were all the people that might respond to an emergency when it was happening. And then in the green were all the different places that these different stakeholders and community members named as somewhere to go. And if you looked at this, you would think, wow, there's a lot of resources in Erie County. And there are. I think, compared to our neighboring counties, we were very fortunate that we have all these bubbles. But when and elected officials sort of looked at this and were like, so what's the issue? Like, you have all these things available. Why isn't it working? You go to the next slide for me. Because in reality, this is how the system played out, right? And this is probably true in your communities too. People call 911, we send police, and they end up at the hospital. So for those, I don't know what the equivalent would be in your state, but CPEP for us is the Comprehensive Psychiatric Emergency Program, which is really a psych ED. To access it, you would go through ECMC, which is our safety net hospital's emergency department for a medical screening, and then you'd be transferred into the emergency department for the psychiatric portion. It is the only 24/7. At the time when we did this interview, it was only 24/7 service available for mental health. So you can see why first responders and even the mental health responders were relying on it, because it was the only place for sure that was going to be open and that had to take whomever you were bringing. So, this likely plays out in communities across the country, right? I don't think Buffalo is unique in its over reliance on 911 and law enforcement for these situations. I will point out that CPEP that I mentioned, it actually covers 8 counties of Western New York. So although my conversation is really going to focus on Erie County, they're a receiving hospital for all the rural and surrounding counties that neighbor us. So they are getting a large population that are presenting with mental health crises. You go to the next slide, please. So one of the things that we realized is there's 4 challenges that as a community we needed to address if we were going to really move forward. And 2 of these are so obvious, but I'm going to quickly go through them anyway. Funding, right? Everyone wants more funding. I would make the argument that there's a lot of funding going into these systems, and I'm not sure we're utilizing those funds as effectively as we could, but there's always need for more funding. And workforce was the other one that if you're on the mental health side or behavioral health side, you are acutely feeling this and have been feeling that for years, right? We are short-staffed, especially in our more acute service providers or evening and weekend providers. But this is also true, we learned, because 911 in Erie County has a lot of vacancies. It is our smallest police academy that we've had in years, right? So it's not just the behavioral health side that is experiencing these shortages of workforce. And then the other 2 I'm going to spend a little more time on. So the leadership team we talked about, right? We kind of knew that since there's no like czar of crisis response, we needed to put together a team that could work collaboratively to make decisions. And then the other piece was data. Admittedly, when we shared this back with the working group that we had started with, they were a little perturbed, maybe is the right word to use. So they're all collecting data. So it wasn't to imply that someone or one agency wasn't doing that, but they weren't sharing it across sectors, right? So the behavioral health provider had their data, the hospital had theirs, Buffalo Police had theirs, the sheriff had theirs, but like there was no coordination of how are we looking at this comprehensively so that we can make decisions for the system at large, right? So everyone was making decisions in silo. And as you can imagine, all the different platforms that these different systems were using, right? So you can't just pull a report and have it make sense, right? Everyone had to sort of turn in their data as it was, and then we kind of had to make sense of it. And that is not an easy task. So I don't mean to shortchange the amount of time that we spent doing that, but it is a really important part of the work that we are doing. Next slide, please. So now we're going to get into the actual work of the collaborative. Next slide. So I keep talking about this leadership team because they are super important. So when they were formed, and we did help in sort of identifying who would be the right people to have on that. We asked them to submit a letter to the foundation, sort of agreeing to terms of play, if you will. So they agreed that they would be active members of the leadership team, that they would prioritize the work being done in each of their sectors, right? So making staff available for meetings, just sending the message to the community and to their employees that this is a priority. And then sharing data, which again, it goes back to what I just talked about. That is a big piece of where I think a lot of communities might hit a wall. We were fortunate that because I think there was a neutral party involved, like the foundation, there was some comfort in sharing that data. And we didn't get too caught up in the legal departments of the city and the county, which was helpful. The other and last piece, which is really important, is we asked the leadership team to be transparent with the community. So yes, they provided us the data, but we were going to share that data back out with the residents of Erie County. And we were going to hold all of ourselves accountable to the residents. So, this happens a lot where there's a big announcement, there's going to be an initiative, and then it kind of like fades off or no one hears about it again. We really wanted to make sure that we were forward facing and being honest about what's working and what's not in our community. Next slide. And we had two overarching goals. And quite simply put, we just want to make sure someone experiencing a behavioral health emergency is connected to the right level of care. If we do that right, then we're going to make sure that they're not being brought to the jail inappropriately or being sort of left at an emergency department because there was nowhere else for them to go. And that would reduce some of the stress that's already embedded into the system. But really, it's just about helping people get the right help. Next slide. So as I talked about, we're approaching it through call, respond, go. So we created 3 working groups around those topics. And as you can imagine, partners might sit on various working groups. So the Buffalo Police sits on all 3. And then, Crisis Services, which is a not-for-profit here in Erie County, which has the name Crisis Services, so it can get a little confusing. They serve on all 3 as well. But there are certainly, like 911 really is just participating in the someone to call. And as I mentioned, we got 12 of the partners to contribute data. Most of 2025 was spent just making sense of that data, learning on our end how to ask for it in different ways, recognizing where there was sort of a difference of language being used between the different systems and how to sort of reconcile that. And in the end, I think we produced a really amazing report about the numbers and what's happening in Erie County, and I'll share that later. And then in 2025, we held 3 community listening sessions. So going back to that transparency, we held one in the city of Buffalo, one in a suburb called Cheektowaga, and then we held a separate one just for people with lived experience. So those who had directly interfaced as a user of the behavioral health system. Next slide, please. I just want to make sure I'm not missing anything in my notes here. I'm going to now walk you through some of the data that we found. And this is where I will gladly, take questions or if something isn't clear, because some people love data. I've learned to love data, but it can get a little cumbersome at times. So the first thing that we learned in Erie County is that we have over 20 public safety answering points, so PSAPs. Our neighboring county has 1. So I don't think any of us really knew that there were so many. And what it is that every town and village in Erie County has a 911 answering center. Even if it's just 2 people working at it, they all have their own. So we knew we couldn't actually do the analysis for 20 PSAPs, right? We had to sort of focus in. And so we chose Buffalo because it's the largest, the most calls originate from Buffalo. And then we chose 2 smaller municipalities to participate as well. Cheektowaga, which I mentioned, which borders Buffalo and kind of has both an urban suburban feel to it, and then West Seneca, which is a truly small suburban town in Erie County. But we're going to focus on Buffalo for today's conversation. So what happens when someone calls 911 in Erie County? The first thing they're going to say is, 911, where is your emergency? And in other places of the country, they'll say different things, but that's what we say here. And we say that because we're going to immediately transfer you to the appropriate 911 call center based on where you're calling from. If you say Buffalo, that call taker is going to hold the call. So our county, Erie County Central Police Services, answers all the calls for Buffalo. So the caller says, I'm calling from Buffalo, and then they go to that sort of green box, yes, and they stay on that side of the screen. And that's who we're going to follow. So the call taker then will ask a series of questions, not necessarily uniform across all the call takers, right? Some of them have a lot of experience, some are newer. They don't follow a set tight script. So they're going to quickly try to figure out what's going on. And then they have three choices, in essence, of what to do with that call. They can transfer it to the dispatch center for police, fire, or EMS. So they'll determine what they think that call is, and they'll send it to one of those places. About 40% of all calls in Erie County are originated in Buffalo. So again, they're getting the bulk of the calls. But what's important to remember is that the dispatcher never speaks to the call taker. So the call taking is done by one person, and then the notes are forwarded and sent to the dispatcher. So the dispatcher will very rarely ever overturn how a call was coded because they have not directly spoken to the person that placed the call. So that's sort of a system that we need to figure out, right? We're relying a lot on these call takers to make that initial assessment and have the whole system operate based on their assessment. Next slide, please. So this is just sort of zooming in on just Buffalo, right? So call, the three places they can send it, and then, what sort of happens. The police either bring that person often to the jail or to the hospital, or they resolve it on scene. Same for EMS would send people right to the hospital. Separately, in Erie County, there is a local crisis hotline and also 988. And those are managed by that nonprofit called Crisis Services. So they run almost like a parallel track to the 911 system. They don't interact with each other. 911 cannot transfer to 988 at this point, or Crisis Services hotline. So they manage their own calls, and then they can dispatch from their calls a mobile response team of clinicians if they think that's appropriate. Next slide. So when we began this analysis, we looked at all the different kinds of codes that the call taker can use. And we only focused on the ones that were explicitly mental health, right? So we've highlighted them here in yellow. For the police, right, that could be a mental health call, a suicide threat. Like, those are the codes that Buffalo actually uses. And then on the EMS side, they just had one, and it was called psychiatric. And so these are the calls, the codes that we looked at. But you can imagine, right, how all these other codes could be mental health related, right? An overdose, certainly, a welfare check, a domestic violence could have implications for mental health issues. And then on the EMS side, someone could be having chest pains, but that's actually a panic attack. So we believe that this number that we came up with is the basement level. We know it's an undercount, but we didn't want to sort of interpret things based on notes that were in the system. We wanted to just go with what was explicitly coded as mental health. Next slide. So here's how the numbers panned out. In 2024, about 10,000 calls were placed to 911 from Buffalo and were coded as mental health. And you'll see that about 2/3 of the time, police were dispatched to that call. 10,000 equals about 3% of all the calls that came in. And if you talked to anyone in law enforcement, they would tell you that that is not accurate, that they go on way more calls than that, that that's not a reflection of how they feel their work is or the day-to-day that they're being asked to do. But if you're looking just at the data and the numbers, that's what it was. Next slide. So here's like sort of a bigger picture of that. So 700,000 calls in Erie County, about 40% into Buffalo or from Buffalo. And then you can see those tiny dark slivers are the mental health coded calls. So a very, very small fraction, right? Just 3% of all the interactions with the Buffalo police were coded as mental health. What's exciting and interesting is that we are getting a new CAD system, so a computer-aided dispatch for 911. What's really unique and exciting about that is that it can code for multiple things. So right now, our current system only allows for one code. So you can see if someone called in and said, my son is experiencing psychosis, he has a knife, that gets coded as a weapon. They don't even go further than that, right? So they're sending it to the dispatcher as a weapon. And this new system will allow them to say, yes, there's a weapon, but also this is a mental health call, right? So just even giving those officers more information for when they arrive on scene can really be a high impact change that we're excited to start implementing. And again, that would explain why some of these codes are so low, right? If you have to choose, you're going to choose to warn the officers about the highest need or risk that they're walking into. And often mental health would be a lower code for that. Next slide. So what is the collaborative doing? So now that we know those numbers, we are working collectively to try and see how we can improve that data collection. And so we believe those are an undercount. So what can we do about it? So 911, right? We can provide better training or additional training for their call takers to be more attuned to things that have a mental health undertone to them, right? But then also, law enforcement, once they're on scene, they know what's going on, right? And so how do we capture what they learned from being on scene? So we're creating pop-up boxes through their police system to indicate, yes, this was a weapon call, but there was mental health, impacted this scene, right? So it's just a pop-up box. Yes, there was a factor of mental health. And while that's not a perfect way of maybe capturing everything, it's going to allow us to fill in the picture more clearly, right? And who better than the police officers when they're staying there to know if there is mental health involved or not. So we feel really confident that we're going to be able to increase all the call coding for mental health just by those two things. And we'll build out other opportunities for better clarification as the work continues. But those are our sort of first two steps. For the whole collaborative, we've established 12 goals. And again, they correlate to either call, respond, or go. And then we have some what we're calling cross-cutting goals that maybe involve multiple partners across the system. Next slide, please. So I mentioned crisis services, which operates mobile response teams that are two clinicians going out together. And what we learned through our analysis is about 45% of the time they're able to complete an assessment on scene. And if you don't know the system, or even if you do, that seems low, right? We certainly would want a higher completion rate for assessments if we're sending out a team of people to do it. So what's happening there? Well, sometimes the person is gone, right? They arrive, they've left the scene, they're not sure where they went to. Also, we're very short staffed for our mobile teams. So the length of time to get there is significant. And families get impatient and then just ask for police to respond instead, right? So they're waiting for the mobile team with clinicians, and then they just decide either things have escalated or they're worried that they could escalate. And so they end up calling back to 911 and having police sent. So there is some overlap of when the mobile team is out and when the law enforcement could be responding as well. But so what's the opportunity? And this is where we were able to step in. We provided a grant to crisis services to almost double their staffing for mobile response teams. But the real challenge is not the funding, it's being able to recruit and retain well-trained staff to work in these positions, right? It's a very high-stress job. Definitely burnout rates are significant. But you want someone with more experience and some comfort in dealing with these critical situations. And so sometimes the funding resolves things and sometimes the funding removes a barrier, but there's still other things that will have to be navigated as the system works to improve itself. So next slide. So this was the objective that we set for the next 12 months. We're rolling these out in July, so you guys are getting a sneak peek here. But it's incremental, right? We don't think overnight they're going to go to 80% completed assessments. But do we think they can go meaningfully from 45 to 65 over 18 months? We do. And if they're not hitting those targets, we're checking on them quarterly. We're going to have in the moment conversations of what is the barrier? Is it the staffing? Is it gosh, we thought this would help with response times, but we're still covering the full county and we just can't get there. And, maybe we need to have some satellite locations for them to be sent out from, right? So we know this isn't solving the problem. We're just starting to take those first steps. And then I'm going to do one more slide and then stop and see if there's any questions. So that final piece of somewhere to go, as I mentioned, CPEP in our area covers not just Erie County, but all the surrounding counties. So they get about 10,000 people a year presenting in their emergency department with a mental health crisis. That is busier than any of the CPEPs in New York City. So we are not as large of an urban area, but we are managing that many people. And as you can imagine, that puts a real strain on the emergency department because many of these people don't actually belong at the emergency department, right? They just didn't know where else to go. And oftentimes police don't have anywhere else to bring them. They know they need to remove them from the scene, but where do you take them, right? And so the hospital has become sort of that default place for the entire system. And interestingly, and I think the law enforcement was very surprised by this, more than half the people presenting at the hospital are going voluntarily. Right. So sometimes law enforcement, I think, feels like they're bringing everyone there. But there's a lot of people in our community that are utilizing the hospital like it's behavioral health services. And so it's not just sort of working with the first responders and people in the system. It's how do we educate the community about all those other bubbles, right? All those other services that might be available or appropriate that we're not utilizing or leveraging in a meaningful way. But you get it. Hospitals are 24/7. Police know that they're going to be open and they have to, receive whomever is brought there. So they can't say, oh, we're at capacity, you better go somewhere else. They are mandated to accept patients that are present there. So what was happening is there was a lot of really terrible press around this hospital locally. And you could feel their strain. Like these are people working, I think, very hard, very committed to the situation, but they were managing all sorts of circumstances that were not actually meeting criteria for their services. So they would screen them and then just send them back out into the community. Nothing is more frustrating to law enforcement than when they drop someone off at an emergency department and an hour later they're back in the town, right? So there was a lot of frustration sort of building and a lack of understanding of what was appropriate person to bring or not. So I'm gonna pause there for a second. That was a lot of information. I'm curious if I'm gonna go through two more slides because I'm gonna finish up the go and then I'll pause if that's okay. So if you go to the next slide. So in New York, we are trying to resolve this overutilization of hospitals for behavioral health emergencies. And the governor has provided funding for what we're calling intensive crisis stabilization centers or alternative treatment centers. And they are 24/7. We had our first one in Western New York open up in January. So a very new service line. It's very exciting that we now have this service available to the community, but I don't know that the community really knows, right? So how can the collaborative, how can all of us as stakeholders help raise awareness of this, educate law enforcement about this as a real good opportunity? Crisis stabilization centers generally are able to take a patient and within 15 minutes, public safety is back on the road. If you go to the hospital here, you could be waiting 4 to 6 hours before that handoff occurs. So it will get law enforcement back on the streets faster. It also is a less traumatic sort of environment for people who are experiencing a behavioral health emergency. There's no inpatient attached to it. It really is like an urgent care for mental health, is the way that I like to think of it. But so this is new. When we did our data, this didn't even exist yet. We knew it was coming, but we really didn't have any numbers to go with it. So next slide, please. But we've set goals for this year now that it's open. So we're making the assumption that as the ICSC begins to take hold in the community and awareness grows, we will see an increase of people presenting there and a decrease of people presenting at the hospital. We'll find out. What could happen is just people that would never have gone to the hospital will now start using the service, and we won't actually be diverting from the hospital. So we're being really intentional about these working groups and how do we make sure we are diverting from the hospital where appropriate. Okay. Last slide on the hospital. And this is going to, one more slide, please. Thanks. It's so expensive, right? And everyone knows that. It's triple the cost if someone is presenting with a mental health emergency versus a different medical emergency in the emergency department. So when we are frustrated that we need more funding, if we can like successfully reduce the number of mental health presentations that don't belong at the hospital, we can reinvest those savings into the system in other places, right? So yes, we need more funding, but also we need to better utilize the system and services we have so that we're not defaulting to these most expensive options when they're not needed. Okay. I am going to stop on this slide. So any thoughts, any questions about the data? Like I said, we have a report that I'm going to make sure we share out to Brenda that covers all the working groups and the different data points that we collected. But happy to hear from anyone in the group if there's something that surprises you, if something feels pretty connected to the work you're doing.
So Jane, I do have a question,
Mhm.
and it goes back to one of your earlier slides when you talked about uh, the leadership table and those individuals and departments that needed to be together to start the informed discussion. Where were individuals with lived experience in this mix? Were they at the table or did they get to the table when you started to have your focus groups?
Yeah, Brenda, thanks so much for raising that. I think I just skipped over it in my excitement of sharing all the data. So while they are not role in the leadership team, which really is more sector-based, policy-driven, we did create a fourth working group that we're calling the advocacy working group. And that's where we invited the partners like NAMI, mental health advocates, some of anyone from the group could be on that, but we really tried to identify those voices that could help inform the work. And then they became the sort of public facing part of the collaborative with the community. So the listening sessions that we hosted, the advocacy working group was the one that helped facilitate those and identify and sort of invite those individuals with lived experience to the table. So we are incorporating their voices that way. We also, in our effort for transparency, put everything up on our website. There is a way for them to communicate. Anyone in the community can email us. We shared what we learned from the working groups, like direct quotes from people that had attended and what their perspective was. So that's how we've been doing it. I'm curious if there's other ways that this group or you could think of how we can ensure that that voice is always present and guiding the work. But we have tried to be very intentional about making those connections and providing opportunity for ongoing feedback. All right, I'm going to keep going. So if you could go to the next slide. So sort of tying into that public transparency, right? So we officially launched in May of 2025. But as I talked about, really there was a lot of work happening, a year or two leading up to that point. By May, we had a pretty good sense of the data. We weren't ready to sort of say we had it perfectly articulated, but we felt comfortable that we could go out to the community, share some high-level data points, and let them know that this work was happening and that we wanted their participation. And then in December, we released the full status report, which again is available on our website, crisistocare.org. And again, disseminated on our website, through the news media, really anyone can access it. And it's, some of those data points are tough. And I think that was something that we as a group had to sort of support each other through. I just showed you crisis services was, completing assessments 45% of the time. I give a lot of credit to their leadership within that organization that they were willing to put that forward, because if we pretend it's going okay, right, we're not going to be able to really correct the gaps in the system. But it's hard, right, to own that number. And so if anything, it's motivating, and we realized they needed more supports than they were getting, that the funding that they had been given wasn't going to meet the community need. And so how do we sort of rally around those partners? Similarly, some of the police departments in their co-responder teams, they had a couple people leave the department, and then the partner that they were using for their clinician match, they were short-staffed. And so, their numbers went down. And that, if you just look at it without any context, is tough. But once you understand, like, this was a staffing issue, not a lack of wanting to do the work. And we really appreciated that all the partners were willing to be that honest with the community about, where there's opportunity, and what they need to access those opportunities. And now we're at the place in 2026, as I mentioned, where we are setting objectives for each of those working groups. We have 12 that we've identified, and we're going to release a report in July outlining those objectives for the community, talking about how we're going to hold ourselves accountable through quarterly reports that we will include on our website. But this is sort of our first step of, now we've analyzed all the data, we have our baseline, how do we move forward? So next slide, please. And so we're at the sort of last piece of this, at least my formal part of the presentation. If you can go to the next slide. And we sort of right back where we started, right? Like, these takeaways, we know what they are. We know that all these things are happening, which makes it incredibly complex. And we are standing by the approach that we're taking, that by breaking it down into these working groups, we have, I don't know if I've mentioned, but over 30 partners and stakeholders that serve on these different working groups. So we've thrown a wide net. We really want to make sure the people that are boots on the ground doing the work are serving on those committees, but we recognize, like Brenda mentioned, the users of the system, the families that are impacted, advocates, who, bring great expertise in different areas that we should be talking about at the state level for policies. But you really need everyone at the table. And, candidly, this is my first time really working with a collaborative, and it can be challenging, right? There's different personalities, different agency cultures. We all want the system to change. We have a shared goal, but our incentives, might be a little different across the different partners. And so really making sure that we keep moving forward, even as there's transitions in partners and things like that. We can't take our foot off the gas. Like, we have to keep the momentum going. Let me see. I think that's the last slide. I think it just goes to our, yeah. So that is our website, thecrisistocare.org. I am so grateful to be sharing the work that's happening here. And, we are looking to expand into some of the more rural neighboring counties. And so, as I'm telling you, every state looks different, every community is different. We'll be experiencing that as we move into our partner counties, where those bubbles would be much fewer, right? They won't have as many that will be named in that initial assessment, and that leadership team will take on a different structure. or composition. But at the end of the day, right, being driven by the data, having the right people who can make decisions at the table together, embracing the different stakeholders and the different perspectives they bring, all of that's the same, right? And while I realize not everyone has a foundation, perhaps like the Lee Foundation, it doesn't have to be spearheaded by us. I think in some of these other places, there could be a community foundation, but also maybe just a strong county mental health commissioner who has the capacity to take on that role, or a nonprofit that is doing the majority of this crisis work. But what's important is that you make sure you keep saying who are we missing, who needs to be here, what perspective isn't being presented, and just keep making room at the table. But law enforcement definitely is an important piece of this, and I think for the prior years, behavioral health was trying to solve it on their own, and that's just not realistic, right? 911 and law enforcement are the first two steps often before someone even could get the mental health services they need in a crisis. So how do we all sort of work together and, as productively as possible? So that's the end of my formal presentation. I know Brenda had talked about maybe opening it up for conversation.
Absolutely, Jane. Thank you so much. Very powerful presentation, a lot of good information. I'm opening up for questions now. Please raise, Jessica, if you could take the slide down. Thank you. Virtual hands, please. Questions.
Did this resonate with folks? I mean, like, I guess I'm curious, like, how different are we here in Buffalo from all of you? And I really do want to learn about what's working, or what are we missing? Like, is there some obvious, as Brenda pointed out, like, what about the people with lived experience? Like, oh, of course we have them. I just forgot to talk about it. But um, you know, what would be the biggest barriers to doing something like this in your community? I know you guys had thoughts. And I also know it's late in the day, so I appreciate that. Oh, Sarah can't raise her virtual hand. Go ahead, Sarah.
Go
Hi
ahead, Sarah.
there. I just want to apologize that I'm not on camera at the moment. I'm sort of multitasking today, but incredibly powerful presentation. Just, I have about 100 questions, but I will limit it to one or two. Um, uh, I would say there's sort of a difference in the field with respect to providers as far as going out in person versus sort of trying to de-escalate on the phone. And obviously, the severity of the crisis matters. But could you speak to that a little bit? Because in my experience, leading an organization that provided this service, when you're dealing with mental health and substance use, we were also in a rural area that was significantly underserved. Having a person, live person in front of the client was incredibly important, not just for the de-escalation piece, but to establish trust. Oftentimes, that was the first time that person had ever encountered the health system. So, could you speak to that a little bit, sort of what your experience is, how you guide and direct your services?
Yeah, so I'll give a little background about in Erie County. So as I mentioned, there's the Crisis Services Hotline, and they also manage 988. So they would be the one oftentimes usually trying to de-escalate or resolve on the phone. If they felt that there wasn't an opportunity to do that, or that needed an in-person response, they can dispatch their mobile response team, which would be clinicians. because they were so short-staffed, sometimes they would flag it and send it over to 911, right? So if they felt there really needed to be an immediate response and that they would not be able to get there in time. So again, parallel systems, but they kind of relied on each other. In terms of police response, we do have behavioral health teams at some of the municipalities, which would be a clinician paired with a police officer, right, going out together. But none of them are 24/7. And oftentimes they're not directly dispatched. They pick up the call when they hear it coming through 911 dispatchers. So oftentimes it's law enforcement, like you said, being that person to respond. And certainly in the more rural parts of the county, that's true. So what we've been trying to do is develop more enhanced training when we do expect the law enforcement will be responding alone. I think also we just have an expectation in society that I called and I want someone, right? Like they don't want to be passed over to a crisis hotline. They called the police, they want someone to show up, and that's the expectation of the person calling. The other complicating factor, Sarah, is most of the time the person calling is not the person in distress, right? It's someone
Right.
seeing that person in distress. So you couldn't even try to de-escalate it over the phone if you wanted to, right? It's oftentimes a family member or a neighbor or someone else that's witnessing something. In some of our more rural counties that are neighboring, they've employed using iPads. So law enforcement will go out and then they can access clinicians, as sort of a consult. And I can think of two counties that did it. One, it was incredibly successful, mostly because I think their law enforcement partners were really open to it. And then the other one, it kind of died on the vine. So they got the funding for the iPads, and this is an example where funding is not the barrier. The willingness or frustration of law enforcement, they're like, I don't want to use the iPad. I feels funny. Like they just maybe weren't comfortable with the utilization of it. So it ended up being that sort of traditional police response. I think ideally, right, you'd want the person to have all those options, which is not always realistic. But we would love to have a 911 when someone was able to be transferred to a clinician or even embed a clinician in 911 to sort of help with those conversations. When there needs to be someone out there, we hope it's the behavioral health team or the mobile team from the nonprofit. But if it's going to be, officers on patrol, how can we best equip them, right, and provide training so that they feel comfortable in those interactions? But
Yep.
it's tough. And I think, with resources stretched thin, New York was very slow to virtual telehealth things. So I actually feel like some states are much further along in that. It wasn't until COVID that you could even do like a mental health telehealth call, forget the crisis, just generally, right? And I know in Texas, they were doing that for a long time ahead of us. So we're playing a little bit of catch up in terms of how we utilize different technology to resolve some of that in-person support.
Yeah, thank you.
Sarah, can you tell me, can I ask a follow-up question for you? So how is it operating in you're in a more rural part, it sounded like. How are they managing or triaging those types of calls?
Well, our rural area has been involved in the statewide pilot led by Brenda and her team, where we have worked, we've brought community stakeholders together, led by our local dispatch. And we've worked out the protocol for being able to dispatch to the local 988 teams when needed. And the groups that have been formed have really built relationships, I would say, among law enforcement and our behavioral health crisis system. I mean, we have a lot of work to do, but that pilot has been very successful. And I know, and Brenda can speak more to this, but I know the results of those pilots are being analyzed now, and we're looking to adopt this widespread in our state. But the challenge is, I can speak in a rural area specifically, are some of the ones you've mentioned. It's really, asking everyone to change their process from what we used to do. The long travel distances, if, an officer gets there first, right? They don't want to wait
Yeah.
60 minutes for a behavioral health provider, not because they're impatient, but because they can't. They might be the only one on shift, on the patrol shift at that time. So the distance in and of itself creates hardship a lot. And then, as you said, showing up and um, not being able to provide a solution, or because of HIPAA, the behavioral health provider might not be able to then discuss at length the situation with local police. There's some challenges there in communication.
Yeah.
But there, on the flip side, have been a lot of success stories as well. But those relationships, as you spoke to, are absolutely critical.
Yeah. And I think, I was thinking about, so Erie County, I focused on Buffalo, but there are, many more rural parts of the county. And the sheriff's office is really who's being the first responder in those cases. And what they've done on the medical side, because even waiting for an ambulance sometimes, right, when you're going out to those farther parts of the county, they've created like sort of specialty certifications so that deputies who are willing to be certified as EMTs or, learn some basic CPR life-saving skills, they, might get a stipend or something like that because they recognize time is of the essence, in all these emergencies. And so now we're exploring with them what would the equivalent of that be for mental health. Like, it is a volunteer situation for those deputies if they want that extra training, but what would be the mental health equivalent of, a mental health first aid type idea of, having a better, not better, but, a trained officer either as the sole responder or, managing the situation until the behavioral health team can get there. So I think, yeah, the solutions will look different depending, although I will tell you, even in Buffalo, our crisis service mobile response team could take 60 to 90 minutes to get there or longer. So even though we're in a city and you'd think that we could get there faster, there's often a lot of complicating scenarios that don't get resolved as fast as you might think or expect. But I appreciate you sharing that. I know that I've had the opportunity to talk to some folks from Tulsa, and they embed one of their CCBHCs into their 911 call taking, and then they can directly dispatch their behavioral health responders from that 911 sort of center. And so that's something that's really interesting, and how they are financing it is through reinvestment dollars from the CCBHC. Because we've looked at embedding clinicians here at our 911 and it is expensive. You need them to cover, right, the full 24/7 shifts. And like, even if they could communicate more effectively with the behavioral health side of the house, the cost is pretty prohibitive at this point, approaching it the way we had initially thought. So, how do we leverage other technologies and things like that? But thanks for sharing that. I appreciate it.
Jane, we have a question.
Yeah.
What type of data sets were aggregated as part of this group that was essential for deciding on what process was best?
Yeah, so we were, as I mentioned, we had 12 partners who contributed data. So that would be the 3 police departments and the sheriff's office. In the early stages of the data collection, we were really looking at the jail presentations, like who was ending up there, and less on the deputy response in the field or the call taking part. But they were certainly key to the data collection. We have the one major hospital that does the psychiatric emergency department. So interestingly, we really looked a lot at their emergency data, the department data, not their psychiatric emergency data, because they had to be screened through the medical side of it before they went there. So those people that were presenting from all over Western New York for a mental health crisis, we were able to capture them best through the emergency department at the hospital there. And then we had a couple behavioral health partners that we asked for data from. So Crisis Services, which is that nonprofit that runs the hotline and the mobile response team. And then there's another nonprofit here called Endeavor, which is the primary mental health provider that partners with law enforcement. They just have a couple of those grants in place. So they partner with Cheektowaga and Buffalo. And so we asked for their data. So we had the police data and then the police partner data, right? The social work data. And it was, it kind of gave us that initial, sort of how are people being dispatched and utilized. 911 obviously was a huge part of the data collection. But, as a follow-up, we asked the police, for their, I think it's called their RMS data as well. So when you just think about all those different types of partners, I think our first go round of asking for data was not maybe as refined as it is now, right? We knew we wanted information, we just weren't sure how it was going to come. Because of HIPAA and these other things that you could imagine, all the data we got was de-identified. So that would be something that we would hope to resolve going forward. We can't follow one person through the system fully, right? Like we don't know, we might know the house number that they're going to, but it could be 10 different people living in that apartment building or, so we can't drill down with that specificity. And I think for our initial purposes, we didn't need to. We really just wanted to see at a high level how people are flowing, the volume that's flowing through the system. One of the things our mental health commissioner for the county is really focused on now is how do we get drill down data? And so they're, talking to some data partners and vendors who could pull together that data that is still has the identification on it and really understand who are these high utilizers. How do we develop plans specifically for those individuals? But the data came together, I think, very well. One of the consultants will say, but I wouldn't build a spaceship with it, right? I mean, we recognize that some of the codings between the two different partners we may be double counting a little bit, not enough that it would change our analysis. But we recognize, we're taking, some people are giving us county data, some people are doing zip code data, some people are doing, so we made the best of what we received. And, the feedback we've gotten is that it's probably the most comprehensive analysis of a behavioral health system in New York State. Again, it was the willingness of the partners to share the data. So we're really fortunate that everyone had that shared commitment to transparency and utilizing data effectively.
Thank you. Jamal.
Yes, good afternoon, and thank you for your time, Jan. I just had a couple questions. So, from a police perspective, are there any data reports that you're able to share with us, concerning arrest and whether suicide numbers are down, officer-involved shootings, those types of
Yeah.
things? Was that data presented and available?
So it's not in that level of detail is not in the report. We do track the 941s, which would be when police put an individual on papers and take them involuntarily to the hospital. And then the jail data would show who was being brought, from those interactions. Where we realize there's like some growth that we need to do on our data side is that probably people are, I mean, the sheriff will tell you more than half the people in the holding center have a mental health diagnosis, but the data is not showing that. And we're thinking it's because they're being called there for a burglary and that's how they're being processed. And we're not capturing that maybe the reason that was happening is because there was a mental health episode going on or something like that. So there's definitely some ways forward to have more certainty around that. I know now we're working with each of the police departments and those are things they're looking at. But in this initial report, it was more like system-wide, how are things flowing? Cheektowaga, which is that municipality that I discussed that sort of borders the city and has a little urban suburban feel to it, they're really on top of like tracking officer involved, use of force, things like that. And so they have them. We just did not include that in this initial report, but they are closely watching that. Sadly, in Buffalo, and I don't, again, realize it's national news or not, we've had 2 officer involved shootings in like the course of a month. And one was absolutely a mental health situation. Actually, we've had 3. So 2 were mental health situations that escalated. One had been called in as a mental health call. So even going to it, they knew that it was a mental health scene. The other one, they came upon someone in the street who was, having what appeared to be a mental health crisis. And then the third one was a domestic violence, but I will, not be surprised if it turns out there's a mental health component to that too. So we've had 3 very public incidences in Buffalo. And as all of you know, everyone has a phone now, right? So they're recorded. You're not even waiting for the police footage at times is right being like streamed on, the social media, what's happening. And certainly the one that was on the street was. So really just, reminds us every day that these situations are happening. I think the public would not realize how common these are for police to be involved in, and like how do we, help support law enforcement, because we are asking them to manage these very frequently. I wish I had the number of how many a day the Buffalo police went to, but it's somewhere, or how many times they brought someone to the hospital a day. But I would love for you to take a look at the full status report, because some of the questions you're thinking might be answered there. But we definitely, each year, we're going to get better at drilling down on that data.
Great. And then one more follow-up.
Yeah.
Of course, not here in my jurisdiction, but in central Illinois, there was an incident where paramedics were stabbed and injured, dealing with a mental health crisis, and they did not have law enforcement there initially. So, of course, that's a scenario where we have to look at some best practices to prevent that in the future. But have you seen that, or have your paramedics, fire departments experience those types of events in your jurisdiction?
Yeah, actually, one of the ones I referred to that was called in as a mental health, ambulance was sent first. So they were the first responders. As soon as they got there, the gentleman had a knife and was threatening them, and so they retreated and called law enforcement for backup. So it's certainly happening. I think we rely on Buffalo, the ambulance, a lot to transport what we'll call the voluntary transports. So they are agreeing to go to the hospital. They're not necessarily being brought on papers, but we need a safe transport for them. And they will ask the police to follow. So there'll be a police escort for the ambulance in those situations, especially if the police are the first ones there, or crisis services, and they recognize that they need that assistance. Something interesting that we discovered was that sometimes ambulance will call fire. So for a variety of reasons, but one might be that they don't think they need someone necessarily on law enforcement, but they need more presence on scene, right? And so fire can get there very quickly usually, and they have a good working relationship with EMS anyway. But we saw that there was a fair number of times that EMS wanted someone else, and felt just the presence of the fire department helped kind of calm and keep things orderly. So unexpected. We're going to be looking into that more. It's certainly, I can assure you that our EMTs and AMRs, our ambulance company, they are part of this working group. Yes, like they feel there are times when they are, arriving on scene and need that additional support. And so how do you manage or triage it in a way that makes everyone safe and comfortable in the environment that they're responding to? But I think it's happening a fair amount.
Great. Thank you so much. I appreciate it.
Thank you.
Are there any other questions? Any comments? I'm not seeing anything. So Jane, let me, on behalf of the state of Illinois, Let me thank you very much for your time this afternoon at our first Learning Collaborative. Um, please reach out to us if you need anything from us. And please direct folks to your report again so that
Yeah. So it's the crisis2care.org. You could also go to the Patrick P. Lee Foundation and you can get connected that way. But I would, if anyone separately wants to reach out or share some thoughts, like I said, we're like the rest of you. We are working through this. We are trying to share things that have been successful for us, but we know there's so much that we can learn from others. So I welcome emails or calls to talk more about it, but I really hope everyone will take a look at the status report, crisis2care.org, and then we'll be releasing that implementation report in a month or two. And I think you can see what our sort of more formal plans are for the next 12 months.
And so for folks interested, we are recording. So the recording will be on the Crisis Hub website as well as the slide deck that will be available also. So with that said, thank you all for your hour and a half this afternoon. I hope you have a great rest of your day.
Thank you so much, Brenda. Thanks everyone for your time.